Well, a warm welcome to this talk, and we're delighted today to be invited to the home of Dr. David Grimes. So, Dr. Grimes, thank you very much for inviting us, and thank you for coming back on the
It's a
video.
Great pleasure to see you again, John, and thank you for coming to this house rather than me going to yours.
Indeed, it's a bit of a trek up the motorway, isn't it?
Yeah, well.
and the last video is on about 1.8 million views, so
I believe so.
there's clearly demand for this message.
Yeah, good.
Now, one of the things, I wish I had £1 for every time someone had asked me, how much vitamin D should I take? Because we know that vitamin D is essential for immunity.
Yes,
that
indeed.
debate is finished.
Yeah.
We know it's essential for numerous other aspects of health.
Yeah.
Reducing chances of cancer, heart disease, probably type 1 diabetes.
Yes.
Whole range of things that we've covered. But how much should I take?
Well, yes, you're quite right. So many people ask this question. It's a bit like diabetes, actually. Someone has diabetes, they say, well, how much insulin should I take? And the answer is, you take enough for you as a person, depending on your body size, etc. And also, you're wanting to achieve good blood levels of glucose and HbA1c. You need, the dose is as much as you need to achieve a good target. You're aiming for a target, and that's what you need. And so that's the same with vitamin D. The question is, what are we trying to do? Well, firstly, we're trying to prevent things like rickets. That requires a tiny, tiny amount of vitamin D. But the other thing is immunity, which requires a lot more vitamin D, quite honestly. Probably 1,000 times more. So, sometimes recommended we should take 400 units of vitamin D. Well, 400, it might prevent a child from developing rickets, but it's not going to do anything for immunity. For that would require at least 10 times as much. Well, we're trying to achieve a good blood level of vitamin D. And the blood level we require is between 100 and 150, actually about 150 nanomoles per litre, and that is 150 is 80 nanograms per mil in the older terms. That's the objective. And if we look at the experience from COVID-19, we find out that people who've got over 100 nanograms per mil blood level, they don't come to any harm from COVID. But the ones with low levels do come to a great deal of harm, can finish up on intensive care units, or they can die. But the blood level above 100 makes us safe from COVID, and probably from other things as well. So when people take vitamin D, ideally they should have the blood level checked. It's like with diabetes, you get your blood tests. It's like with hypertension, you get your blood pressure measured. You're trying to achieve a target, and that's what we're trying to do. The amount of vitamin D an individual requires to achieve a target level of over 100 nanomoles per litre, that varies from person to person, quite honestly. But a good starting point is to say, well, what is a unit of vitamin D? Now, a unit of vitamin D is like a unit of insulin. They were both discovered at about the same time, 100 years ago. It was not possible to weigh them, to develop a mass measurement. It was only possible to have a biological measurement. And the biological measurement of vitamin D is that 1 unit is the daily requirement of a 10-gram mouse. So, when you say how much do we need, let's start off with the 10-gram mouse, 1 unit. Now, 1 unit of per 10 grams means that for a human with a body weight of 60 kilograms would require 6,000 units.
I think I'm slightly more than 60 kilograms, but yeah.
Yeah, that's right. Yeah, absolutely. Yeah. We'll choose 60 kilograms, sort of vague average, but average weight does tend to go up over the years.
Yeah.
So that's a good starting point anyway. We say, well, 6,000 units sounds like a lot. People say, well, that's a big number. Yes, it is a big number, but it relates to the 10-gram mouse. What we should have, perhaps, is kilo units. And so then, we, rather than 6,000 units, we'd have 6 kilo units, which, you know...
Like we do with calories.
Yes, indeed, absolutely. Yeah. So, anyway, we don't do that. And so, we'll say, OK, if 6,000 units sounds about right for 60 kilograms, let's make a start on 3,000 units.
Which is very conservative.
It is conservative. The Standing Advisory Committee on Nutrition, SACN, was advising 400 units, but does admit that 4,000 units is perhaps the maximum that should be taken. What evidence for that? I don't know. It's the fear of overdose of vitamin D, which we'll come back to shortly. But let's say we start on 3,000 units a day and then get your blood tested after 6 months, say. See what it is. And if it's not up to 100, you increase the dose. Like you do with insulin in diabetes, like you do with your treatment of hypertension. You judge the dose by the response it's had.
It's the titration, isn't it?
It is a titration.
Start off on 3,000.
Yeah.
For most people, I think it would be fair that we probably need... I'm sure I need about 8,000 a day personally for my body weight.
Well, I think that's right. So you could argue that someone weighs 120 kilograms far in excess of your weight might need 12,000 units a day. But again, it's a matter of measuring it. With body weight, by the way, the obese people do not have good blood levels of vitamin D. The vitamin D they produce in the skin tends to be soaked into the fat cells of the body, and it doesn't seem to come out again. So if you take an obese person and a non-obese person, expose them both to the same amount of sunlight or UV light, the obese person will produce perhaps only half the amount of vitamin D as measured in the blood than the non-obese person. So obese people do require more vitamin D. And that's factual. But again, it should be managed on the response. Now, ideally, with immunity, we say, well, what is the best measure of immunity? How can we measure immunity? Well, we can't really. We can measure antibodies in the blood, but that's only a small component of immunity. There's no easy measure of immunity. In fact, the blood level of vitamin D is a reasonable surrogate for measuring immunity. Because we know if people have high levels of vitamin D in the blood, good levels, they don't get infections like flu or COVID. And if they have low levels of vitamin D, they do get a lot of COVID, flu, and also a lot of other diseases as well. So immunity is best measured actually by vitamin D. Anyway, so we start off and we measure the response and we get there. And somehow it's going to be about 6,000 units a day. That seems reasonable, and it is perfectly safe.
So it's quite possible that you could give you and me 6,000 units of vitamin D a day each. And for genetic reasons, for microbiome reasons, for maybe 1,000 reasons we don't understand. I don't understand, certainly. We could end up with really quite different levels. There's a difference in response.
Indeed.
Now, what I find really curious here is that the vitamin D levels that are advised were basically worked out to prevent rickets back in the 1920s.
Yes, that's right.
And we've learned all these new functions and no one's bothered
indeed.
To update the requirement. It just seems utterly bizarre. And I think when we transpose those, so like if we have 4,000 units of vitamin D, that's only actually 100 micrograms. Isn't it? It's 100 micrograms, and that's a tenth of a milligram. Is it? Yeah, 100 micrograms. 100 micrograms is a tenth of a milligram.
Yeah. One microgram is a thousandth of a milligram. Correct. Yeah. Which is a thousandth of a gram.
So we're dealing with actually tiny amounts.
Well, it's now possible to measure the mass of vitamin D, and 1 unit weighs 25 billionths of a gram.
Yeah.
Now, it's not very much.
Yeah, yeah.
So what you find out, that when you get capsules of vitamin D, no matter what the dose of vitamin D is, they all look the same.
Yeah.
And people can't get their minds around this for obvious reasons.
Actually tiny.
But 99% of the content of vitamin D capsule is olive oil. There's a tiny bit of vitamin D by mass and by volume, because it's an oil. Yeah. So
why can't we test immunity by doing a differential? I'm sure you've ordered differential white cell counts about 10,000 times.
yes, that's right. But that's
Looking at the different types of white blood cell.
yeah, that's right. It
So
still
could
doesn't
there be
quite work out.
Could there be a situation where you had the right number of white blood cells, the right number of lymphocytes and the right number of neutrophils, but because you haven't got enough vitamin D, they could be physically present,
Yes.
but physiologically suboptimal in their physiological activity.
That's the problem. It's the function, not the structure. The T lymphocytes are critical, and the T lymphocytes are very dependent on vitamin D for their activation, but also very badly damaged in AIDS. And AIDS, of course, leads to infections, malignancies, because immunity is suppressed. And it gives a very good example, actually, of how immunity is suppressed. When it is suppressed, it leads to a lot of illnesses, strange infections, malignancies in AIDS, heart disease in AIDS, dementia in AIDS. A lot of things came out in AIDS which told us the importance of immunity, and in particular T-cell function. Now we're seeing at the moment that I was reading just in the newspaper this morning, in the Guardian this morning, that there's an increase. No, it wasn't. It was the British Medical Journal I was reading this morning.
That's bad.
So there's an increase. There's been a 10% increase in tuberculosis from 2022 to 2023. And previously, there's been an increase in the past few years, suggesting that our immunity is damaged at the moment, which is why the tuberculosis is appearing. And I also read there's an increase in leprosy as well. Now, tuberculosis is a key to immunity. And that is what happened in AIDS. A big increase in tuberculosis with AIDS. And that's my feeling now, is that with repeated vaccinations and infections, we've been depleted in vitamin D. Because every time we respond to an immunisation, a vaccination, or to an infection, we use up vitamin D, because one molecule of vitamin D can only be used once. Then it's inactivated irreversibly. So I think that the problem at the moment, why there's been a lot of additional illness, and there is a lot of illness, no question about it, the ambulances aren't queuing up at the hospitals for no reason at all. It's because our immunity is damaged, and I think we need vitamin D in a big way at the present time. It's a public health imperative, really, but it's not happening.
And there's a lot of people watching this video feel a bit run down, a little bit tired. It's not spring yet. We're still at the end of winter.
Yeah.
And, most people like me have had one or two viral infections over the course of the winter. Those viral infections are going to use up my vitamin D. So I'd have much lower levels of vitamin D after a couple of viral infections, and it can be really quite low.
Yeah.
And that can give rise to sort of physical symptoms. I mean, if you are very low on vitamin D, how might that make you feel? I mean, is the tiredness, the heaviness, are they features of it?
I'm not sure, quite honestly. I wouldn't say so. Might be true, but I'd really just go for the infections and the specific diseases rather than how you feel.
Right.
People say, how can I recognise that I'm deficient in vitamin D? And the answer is, well, you have a blood test,
Yeah. How do I know what my blood pressure is?
That's right.
Well, you take it.
Absolutely. Yeah. You've got to have the test done.
I think there's an important point there, though, because a lot of the diseases that are associated with vitamin D, by the time you've got them, it might be a bit tricky to treat them.
Yeah.
Dementia, for example.
Yes, indeed.
I mean, there's no question in my mind that chronic lack of vitamin D is an etiological factor in dementia and potentially other neurological diseases. Have you got any thoughts about the connection between vitamin D and neurological diseases?
Well, I think it's true to say the strongest one is multiple sclerosis. But that goes back to birth, because a baby born in the spring will have an increased risk of developing multiple sclerosis in adult life than a baby born in the autumn. Now, the autumn birth means the mother was pregnant during the summer and that she was there getting vitamin D to pass on to the baby in the uterus. And so the baby born in the autumn has a biological advantage in several different ways. Whereas the baby born in the spring, the mother was pregnant in advance in the last 3 or 4 months of pregnancy during the winter time with no vitamin D. Now, to my mind, no baby should be born in this country or anywhere deficient in vitamin D, because I think every mother, every woman who goes to the antenatal clinic should have a blood level vitamin D check there and then.
But this isn't done.
It's not done now.
Folic acid, we're well aware of the rate.
Yeah, that's right, exactly. Folic acid, yeah. There's been the Sure Start project, which we had in Blackburn, which I was part of. And with that, we gave mothers, expectant mothers, vitamin D during pregnancy. But the Sure Start project has been cancelled. It's a central project. It's been cancelled, unfortunately, by government. So that doesn't happen now. But really, we should be checking the pregnant women, protecting them. There's a lot of evidence that vitamin D deficiency is related to eclampsia. Oh, what do they call it? PET now?
Yeah,
pre-eclamptic toxemia, pregnancy.
The high blood pressure, the proteinuria, the edema.
That's all, yeah, indeed. So a more successful pregnancy requires vitamin D and the baby after it.
Amazing, really. So we've got 3 things there: the health of the mother, perhaps optimising fetal development, and making sure the baby's vitamin D level is topped up when it's born. So as soon as a baby's born, it's going to be assaulted left, right and centre from the milieu of viruses and bacteria.
That's right. We hear about rickets in young children. That should not happen. It particularly occurs in the children of Black African and South Asian ethnicity, because their mothers, we know very well, are going to be deficient of vitamin D. People with dark skins do not produce enough vitamin D in the environment of the UK, where we're living closer to the North Pole than to the equator. And of course, the South Asian ethnic women tend to cover up with clothing as well, rather what you might call excessive.
Guaranteed, isn't it?
It is, and it's well known.
Yeah.
So at least these poor women should be checked. These women should be checked. The ethnic minority women should be targeted in particular, but they're not being, I'm afraid to say.
But even I'm pretty white, as you can see, and last summer I got quite a bit of sun at the allotment. So for about 5 or 6 months last summer I didn't take any vitamin D, and I actually managed to persuade my GP to check the levels. At the end of, it would be about September, the very end of summer, and I was pretty confident it would be topped up because I had a lot of sun exposure, and it was only about 75 nanomoles per litre. So even me being white, spending quite a lot of time in the sun, still didn't have anywhere near optimum levels of vitamin D. I was very disappointed, and I've certainly gone back onto the supplements now. I'm sure.
A lot of people say that, well, I'm out on my bike, I'm out on my allotment, I would have plenty of vitamin D. And it turns out that they often just don't have. You know, we've got a day today. It might still be the end of the winter, the sun's still lowish in the horizon, but it's all grey skies, it's all cloud.
Yeah.
You know, we've got cloud coverage, we've not got any brilliant sunshine.
No.
And it's often the same in the summer.
So my basic science is a bit challenged. Is vitamin D a vitamin or a hormone?
It's a hormone, without any shadow of doubt. Right. It's a hormone that's produced in the skin. We produce an oil in the skin called 7-dehydrocholesterol and DHC, we call it 7-DHC, and the sun converts that into vitamin D, which enters our body, activated partially in the liver, and then activated fully in the cells. It is a hormone. The point is that it's not just humankind that produces vitamin D from 7-DHC. It starts off with plankton, which evolved 1.5 billion years ago, and they produce 7-DHC, the oil, as a sunscreen. And it absorbs sunlight energy, it's converted into vitamin D, but the plankton have no use for vitamin D. Firstly, they don't have a skeleton, so they don't need it for bone. And they have a very primitive immune system which does not require vitamin D.
But they don't get sunburned.
No, they don't get sunburn.
But no, that's not a joke. That's true, isn't it?
It's true.
To protect them from the sun.
That's one of the two mechanisms of see, plankton live close to the surface of the sea, so they are actually prone to UV damage. Yeah. But the 7-DHC absorbs the UV energy to a large extent, and vitamin D is the waste product. But plankton also tend to sink during the daytime and rise to the surface during the night time. It's called diurnal vertical migration, it's called, which again protects them. Now, fish don't produce vitamin D either, because they have scales and they live deep in the sea. But fish eat plankton. It's the start of the food chain, and we eat fish.
Do fish need vitamin D for their physiology as well, then?
Yes, they will do. Yeah. Yeah, certainly. So the bony fish need it for the bones, but all fish will need it for the immunity.
Of course, bony fish have got bones, obviously.
Yeah.
Never thought of that. No, seriously. Of course, so they need vitamin D, absolutely.
But land animals also produce vitamin D as a hormone in the skin. And we eat land animals, and we take vitamin D from meat. But our vitamin D supplements come from sheep, because sheep produce vitamin D in the skin. And when the fleece is taken off in the summer, when it's too hot for them, the oil of the wool contains vitamin D and it's extracted. And when we have vitamin D supplements, it comes from the sheep's hormone. We call it a vitamin then, but we're not taking in a vitamin, we're taking a hormone from the sheep. It's like if we're short of thyroid, if we have an underactive thyroid, we take thyroxine tablets. Well, the thyroxine comes from animals. The animals produce the thyroxine, and we take the thyroxine from the thyroid extract from the animals. It's not as primitive as that these days, but nevertheless the principle is all the same. So, yes, vitamin D is a hormone. It's called a vitamin because we do get it from the diet as well.
Of course, that's how insulin started. I mean, I remember when I was a young staff nurse giving bovine or porcine insulin.
Yeah.
Before the human
indeed.
insulins.
Absolutely.
Before they came along.
Yeah. Insulin's a hormone, and if we don't produce our own hormone, we got it from the animals, from the sheep and the pigs. Yeah.
And it's not just the sheep being kind to humans, all woolly animals.
Yeah.
I think dogs do this as well.
They do it. When you see,
they produce this precursor, the sun hits their hair, and then of course what do? Well, they lick it.
They lick it. That's right. They lick themselves and something and another one.
Yeah,
that's right. That's how it gets into the bodies.
One thing that concerns me slightly is that we tend to put sheep through sheep dips with organophosphates.
Yeah.
So, do you think the supplements we're getting contain nasty things like organophosphates as well? Do we know about that?
I don't think so. I think that the organophosphates are water soluble. Well, they are. Sheep dip is through water. Right. Whereas when the fleece is washed to get the oils out, it's an inorganic. It's an organic solvent. I don't know if it's something like xylene or toluene. I'm not sure exactly what it is, but it comes out in the. It is a fat, so it doesn't come out in the water. And
of course, the vitamin D is fat soluble, which is convenient.
Absolutely, yeah. I don't think there's a danger there at all. No.
So interesting that all animals are requiring vitamin D. It's ubiquitous, and it's just a sort of philosophical point, really, isn't it amazing that something that algae, shall we say, invented,
Yeah.
were given, created as a sunscreen, just happened to be essential for all higher physiology.
Absolutely amazing. It really is.
Quite.
Evolution is a difficult thing to understand. But coming back to the creation of vitamin D...
Difficult stroke impossible, yeah.
That's right. Yeah. Coming back to the vitamin D in our skin.
Yeah.
It's okay, we produce vitamin D, we synthesize 7-dehydrocholesterol, 7-DHC in the skin. The sun converts it into vitamin D. But the problem is, when we get old, we don't produce the oil in the skin.
Oh, that could be my problem last summer.
It could well be.
Yeah.
It could well be. But, or part of it anyway. But very old people are always deficient of vitamin D. It's inevitable because they've got dry skin. The skin is not producing adequate amounts of 7-DHC. And therefore, it doesn't matter how long they sit in the sun, they're not going to have adequate amounts of vitamin D. When we give them a supplement, they just need a normal supplement, a normal dose.
That's what I was going to ask. Do old people, obese people, people from different races, do we all need actually the same amount of physiological available vitamin D?
Elderly people, people with pigmented skins, dark skins, all require the same amount of vitamin D as a supplement. But obese people require additional. They require more. But the amount required depends not on age or skin colour. It depends on body weight, effectively.
Got it. And of course, it's fat soluble. So if people had a lot of adiposity, a lot of fat cells, the vitamin D would simply just diffuse into those cells. That's simple physics, isn't it? And
it is indeed.
Would hide away, and it's not there to be used.
Could you just go back to our discussion on units?
Yeah.
As well. Now, you'll know that insulin is also given in units, and effectively, the starting point is a normal person would produce about 1 unit an hour.
Okay.
About 24 units a day. That was the simple starting point.
Interesting.
But it's measured in units. Now, no one has been stupid enough to decide to alter the dose of insulin from units into micrograms.
It's about 34 point something, is it?
It's something like that.
Well, basically not to know, isn't it? Better not to know.
It's better not know.
It's about 34 micrograms of insulin per unit, I think, something like that.
You can imagine the chaos that would result if someone decided,
teaching student nurses,
these units of insulin, that's early 20th century measurement. We're now in the 21st century. We're much more scientific. We'll now use micrograms of insulin. It would cause chaos.
And multiple deaths through overdoses all around the world.
Wrong. Yeah, indeed. Overdose, absolutely. Now, there's been no move for that. That's common sense. But our SACN, Standing Advisory Committee for Nutrition, expresses vitamin D in micrograms. Now,
because they're clever and modern and scientific.
That's exactly it. But also very, very stupid, I'm afraid to say.
Well, apart from that, yeah.
Now, okay, so that's what SACN says, micrograms. The average person has never heard of a microgram.
No.
I went along to our local pharmacy the other day and I was getting some vitamin D capsules for a friend. And there was one packet, it had on it only micrograms. It didn't say what the units were at all. It usually says both, but it just said micrograms. Yeah. So I went to the girl at the counter, not the qualified pharmacist, and I said to her, what does this mean? And it had μg, microgram. Yeah. I said, what's that? She says, I don't know. She said, I've never heard of that. I said, well, it means a microgram. Now, people who do not work in a scientific environment do not know what micrograms are. There's no reason why they should. No. Milligrams, people know of milligram. That's your tablets, but you get your tablets. I take flecainide, 100 milligrams twice a day. Easy. to remember. Everyone's accustomed to micrograms. Everyone's accustomed to milligrams. To say 100 milligrams twice a day. We know about milligrams, but micrograms, 1,000th of a milligram. Now, if you're told to take 400 micrograms, I'm going to get myself lost in numbers here.
If you're told to take 400 units, as we are, that would be 10 micrograms.
That's right.
Yeah.
To 400, 100 micrograms to 4,000 units.
Correct.
But if instead of that you take 100 milligrams, you're taking 4 million units a day.
Yeah, which wouldn't be conservative.
Yeah. And that's where things can go horribly wrong.
Yeah.
Because people confuse micrograms and milligrams. And I've seen this in the newspapers. Headlines, take 100 milligrams a day. Well, you know.
A lot of medical journalists have got BAs in journalism.
Yeah.
And don't know these things.
Absolutely.
It's a real risk. So I agree. Let's stick to units.
Keep to units. Forget all this micrograms.
Yeah.
Keep to units, because we all know what they are. We've got 100 years of experience of units. Let's keep to it. Let's do like the insulin people are doing.
Yeah.
Keep to it.
I'm not going to mention the old days where we had insulin with 20, 40 and 80 strength. We'll ignore that. It's all now 100 strength. So.
Yeah, it is that. Standardised, yeah.
It took me 3 years to memorise all that. Then they changed it all. So
they did, absolutely.
but that's okay. So getting back to the vitamin D is going to be activated. So it goes to so whether it comes from your skin, that's the vitamin D3. Or it comes from a tablet, that's the D3. That goes to the liver.
Yeah.
How long does that activation process take?
It takes several days, should we say?
Yeah.
Up to perhaps a month before the high blood levels are achieved, before full conversion has taken place. It's a slow process. There's no reason for it to be fast, because ideally we're producing vitamin D every day. So it's just a daily top-up.
So you keep putting it at one end of the pipeline, keeps coming out the other.
Yeah. If we take 3,000, 4,000 units of insulin, of vitamin D a day, 3,000 or 4,000 units of insulin a day, so I've said it again. If we're taking 3,000 or 4,000 units of vitamin D a day, and the blood levels are the same, that means we are consuming 3,000 or 4,000 units per day.
Yeah.
We require that to keep us fit and healthy. Now, if we take a dose, if we are very deficient in vitamin D, and we take a single large dose of, say, 20,000 units, which is generally speaking a week's supply, then it'll take a week for the blood level to come up to an ideal level.
And that takes us into the storage form.
Yeah, it does, yeah.
The Calcifediol.
Absolutely.
Storage form.
The storage is not in the fat cells. The storage is actually in the blood itself.
So it's just ready to go when we need it.
Yeah, ready to go. It's circulating, ready for action, in contact with all the cells of the body. So when they're triggered, there's an infection taking place, they pick up more and more vitamin D from the blood, and then they reprocess it and reactivate it ready for action.
How long does it take the cells to get the vitamin D working from taking it from the blood?
It's more or less instantaneous.
Right, so it's a week or so to get the vitamin D through the liver.
Yeah.
But once it's in the blood, it's banging, it's there.
Yeah, it is indeed.
Right.
Now, what we require, the problem is when we take vitamin D in its raw form, or we produce it in the blood, and we produce it in the skin in its raw form, it has to be circulated and taken up. If we take it by mouth as a supplement, and from the skin, it's got to go through the liver, and that's the slow process.
Which takes time, yeah.
And if we're very deficient, but seriously ill, it's going to be a week or so before we get the vitamin D that we need. into the immunity cells.
And we just get this all the time. Every shift on A&E, you'll get several patients in with sepsis, respiratory sepsis, urinary sepsis, or if not sepsis, severe infections.
Yeah.
So there's no point giving them high doses of vitamin D as soon as they come in.
No, the high dose side doesn't work. The high dose doesn't get action any quicker. It's got to go through the liver. That's the hold-up. But we can bypass the liver. What the liver does, it adds an OH group, hydroxyl group to vitamin D to put it into the blood.
This is the Calcifediol
That's
blood
right.
storage form.
Yeah, absolutely.
Yeah.
But we can give that form by mouth.
Well, why on earth don't we do that every time someone gets an infection?
Yeah, because that part activated form, the Calcifediol, that is absorbed into the blood within about 2 hours. Whereas it will take up to 2 weeks for the raw form of vitamin D to become activated or pod activated. The Calcifediol, it takes 2 hours.
So we have an immune optimizer that goes into the blood within 2 hours, and that is working one heck of a lot quicker than antibiotics,
it is,
which are going to take, even IV, they're going to take 4 or 8 hours to work.
Yeah.
And that's going to work. And then the cells can use that straight away. The white blood cells could use that essentially instantly.
Instantaneously, yeah.
So we could be getting the immune system really roaring into gear in my septic patients within 2 or 3 hours.
Yeah, absolutely.
And yet so what we have in emergency departments, we have something called the sepsis 6.
Yeah.
So we get them in and you've got to tick them all off and it's got to be done within an hour, rightly.
Yeah.
So first one is oxygen.
Yeah.
The next one is IV antibiotics.
Yeah.
The next one is checking lactate. I might be out of order. Checking lactate and hemoglobin.
Yeah.
Intravenous fluid resuscitation.
Yeah.
Checking the urine output. And may have one other one I've forgotten. But really, we should change that from the sepsis 6 to the sepsis 7 then. We should be giving Calcifediol.
I'm sure.
Because all of those things that we're doing, apart from giving the antibiotics, not really affecting the infection. It's just monitoring the body's response to the infection.
Yeah.
Antibiotics
won't work if the immunity is no good. We've got to have immunity. Antibiotics are very useful, obviously, very, very, very important. But the immunity system, the natural immunity in the body, is of vital importance, and we've got to make sure it's optimal, that it's working properly. And the thing that keeps it from working properly is vitamin D deficiency. Now, we could come on to, you mentioned coming to hospital seriously ill. And the other thing is, one thing that makes you seriously ill is having an operation, quite honestly. A major operation means you're temporarily seriously ill.
Yep.
And you've got to get over that operation. And that requires defensive immunity as well. And it's been well worked out that postoperative complications are more common in people who are vitamin D deficient. So, preoperative check when you go into hospital, pre-op check should include a vitamin D level of the blood.
But it doesn't.
For a major operation.
I mean, why is it, It's so obvious.
It is indeed, yeah.
Well, why haven't the health authorities worked this out? I mean, it just seems inexplicable that you wouldn't want to optimise
That's right.
this wonderful natural immune system that we have.
It is. Yeah, absolutely. See, you and I believe in nature.
The created
and we've
order.
got to believe in nature.
Yeah.
We've got to optimise our natural immunity.
Yeah.
And we know we're all vitamin D deficient. We know we work indoors, not in the fields. We know we have a lot of clothes cover. We know we've got a lot of cloud cover. We know that half our year is we don't produce vitamin D because it's winter. We know all these things. Let's put it all into action. There was a photograph in the newspaper last week. It was of a little Afro-Caribbean, Black African ethnic child. And it said he was to illustrate a finding that's come from the paediatricians that ethnic minority children have a much higher complication rate after they've had their appendix removed. They're slow to recover, more complications. Why is this? Is it something to do with racism? Well, it's glaringly obvious.
Yeah.
It's glaring. We know very well that these children from ethnic minority backgrounds are born deficient in vitamin D. We know that vitamin...
Probably deficient when they were a fetus.
Yeah, absolutely, yeah. We know very well that vitamin D is essential for optimising immunity, and we know that post-operative complications are more common in people with defective immunity, and also in people who are vitamin D deficient. We know it all.
Let me see if I can work this one out. It's just so obvious.
It is indeed. But in this article in The Guardian, I think it must have been, this article, which is based on research done by, I think, paediatric groups, was never mentioned the possibility of vitamin D deficiency. And it can be put right immediately.
Yeah. With Calcifediol, literally immediately.
Yeah, absolutely. Yeah,
yeah, within 2 hours.
Yeah. In fact, absolutely.
There's two other lines of evidence that the first line of evidence that convinced me about the accuracy of what you're saying. And I think we should say that you are one of the pioneering researchers and publishers on this. You did the early work on this way back in the 80s and 90s. So one of the lines of argument is why are we white? Because presumably our ancestors would be, if the out of Africa theory is correct, they would have been dark-skinned.
Yes.
And the evolutionary advantage in turning white as we migrated north is really the only reason. Okay, we might produce a bit more nitric oxide, but I was working with some colleagues in Africa recently, and I was going out in the morning and putting sunscreen on, and stopping putting sunscreen on.
Yes.
And they said, "John, what are you doing?" I said, "Well, if I don't put this on, I'll burn."
Yeah,
and, and these were doctors and things. Said, "Oh, really? You burn in the sun?" To them this was a novel concept.
Strange, isn't it?
So that's one thing that we became white. Our ancestors, Cheddar Man, I think around about 8,000 years ago, found in the Cheddar Gorge. He had blue eyes, dark hair, and dark skin.
Yeah.
But he was British.
Yeah.
He was in Britain.
Yeah, indeed.
So we've evolved. So that's completely convincing.
Yeah. I think we got our white skin from the Neanderthals.
I was.
And the other interesting thing is that the major ape gorillas are white skinned.
Really?
They're white skinned, but they're covered with hair. And I think the Neanderthals were white skinned, but they were hairy to protect them. But certainly we have an advantage in this climate, as I say, close to the North Pole and to the equator, because we become vitamin D deficient, but not as deficient as the people with dark skins.
Who live in this climate, And of course, Neanderthals were largely a northern species.
Northern European, African,
so it's not surprising they were white.
Another thing about the in Africa, and the doctors not understanding about the skin getting burnt, they should have done, because in Africa there's a huge problem with children or adults who develop vitiligo, where the skin loses its pigmentation and they get patchy white skin, and it burns terribly.
Yeah,
it really does. And also the genetic condition of albinism does occur in Africa.
Yes.
And a child who's born as an albino with white skin is a terrible condition to have there. They get terribly burnt.
Yeah. And the other line of evidence that was convincing, apart from me being white, was if we take traditional cattle herders like the Maasai, other groups in Africa, Karamojong, that live in their kind of natural environment, they've got very, very dark skin, but they're outside all day, every day, under the tropical sun. And their levels of vitamin D in that, what you could say is a completely natural human environment, is well over the 100 nanograms per nanomoles per litre. Well over the 100, sort of the 150, 160 kind of range, which suggests to me that presumably they've optimised that over tens of thousands of years.
And that seems to be the optimal level, around about 150 nanomoles per litre. But it doesn't go higher. And people do not get vitamin D excess from the sun. And it's considered that any excess vitamin D in the blood is inactivated by the sun. The sun has a controlling effect both on the production of vitamin D and on the blood level of vitamin D.
So that means if I took a lot of vitamin D supplement but was out in the sun,
Yeah.
my levels probably wouldn't go too high. But if I took a lot of vitamin D supplement and lived indoors,
Yeah.
there is the potential
Yeah.
for overdose. Now, you've been a doctor for a long time. Have you ever seen a case of vitamin D hypervitaminosis?
No.
Neither have I.
It is staggeringly rare.
Yeah.
And is always due to either stupidity or mixing up the dose, micrograms, milligrams.
But okay, which is 1,000 times different. Suppose you were in a really bad mood and you wanted to give me too much vitamin D.
Yeah.
So it caused high blood calcium, hypercalcemia.
Yeah.
How much would you have to give me, probably, in terms of probability?
Probably over 100,000 units a day.
For
Yeah. And also with calcium.
for days and weeks?
With calcium. If you're taking vitamin D, you shouldn't be taking calcium. If you're taking a higher dose of vitamin D, don't take calcium. Because that can lead to problems. We don't need calcium. We're not short of calcium. There's plenty of calcium in the diet, but we need vitamin D to absorb calcium from our food. If you're taking a good dose of vitamin D, you don't need calcium.
Where are you on the K2 bit?
I'm not, quite honestly.
Right.
I'm not.
So, I mean, if you take K1, the bacteria in our colons are going to produce vitamin K2 for us.
Yeah.
But there again, we don't eat much fermented foods in this country. But
No, indeed. It's a new thing which I don't know an awful lot about, to be quite honest. The idea is that the K2 prevents the calcium being deposited in the tissues. Well, calcium is deposited in the tissues where there is chronic inflammation, and it's not very common actually either. You know,
we see occasional drain pipe arteries, don't we? Where
we
you
do
can sort
indeed
of see the calcium in there.
That's because the arterial disease is due to chronic inflammation. And the chronic inflammation is there because the people are vitamin D deficient. You know, you don't get the chronic inflammations when you've got plenty of vitamin D on board.
Vitamin D is an inflammatory modulator.
It absolutely, it does. See, when we get an acute infection, we had a body response which is actually orchestrated by something called TNF alpha, tumor necrosis factor alpha, and that's orchestrating this acute response.
It's a pro-inflammatory.
Absolutely, yeah.
Cytokine.
But that has to be switched off. Do you remember the cytokine storm in COVID? That was TNF alpha produced, modulated.
Too much of it.
And what it has to be done, it has to be switched off. And it's called the macrophage balance hypothesis. The macrophages, white cells in the tissues in particular, are producing TNF alpha, and it has to be switched off to produce something called TGF beta, transforming growth factor beta.
Which is a damper downer.
It's a healing one. It damps it down. It's part of the specific targeted defensive immunity then. So we're going from TNF alpha to TGF beta, and that transformation is modulated by vitamin D. So vitamin D is going to switch off the acute response and come into a healing, specific defensive response.
So inflammation is good during an acute illness.
Yeah, absolutely.
Or an acute illness. So
it's essential.
If I twist my ankle, I'm going to get heat, pain, redness, swelling, loss of function.
Yeah.
Which is taught that a few times.
Yeah.
Which is part of the necessary healing response. The blood vessels will dilate, the nutrients will come out.
Yeah.
And we know this is essential because if we give people high doses of hydrocortisone or dexamethasone, and we switch this inflammatory response off,
yeah.
then the ankles won't get better, and worse than that, they'll probably get pneumonia and die.
Yeah.
Because we need this inflammatory response. But then once we've had it, we need to go from the inflammatory phase, done and dusted, thank you very much, got rid of the bugs. Yeah. Then we need to go on to the healing, regenerative phase.
Yeah, absolutely. That's
and to do that switch, if we
yeah.
haven't got the vitamin D to switch off the pro-inflammatory stage, then the inflammation can kill us.
Yes. What's often called autoimmune disease is inflammation that's not been switched off. Chronic inflammation, low-grade inflammation, it's not being switched off. And you often find vitamin D deficiency is at the basis of that. And of course, then you get tumours. Tumours have been called wounds that do not heal. Chronic inflammation leads to cancers. The inflammation is not being switched off, and then you get a transformation into cancer. And you find chronic inflammation in the skin, in the uterine cervix, in the esophagus, in the pancreas, in the gallbladder, in the colon, in the breast. I'm sure I've not gone through them all. All these areas of chronic inflammation that lead into cancer.
So it's quite reasonable to say that optimising vitamin D levels could well reduce the chances of pretty well all forms of cancer.
Yeah, and perhaps not all, but most.
Most,
yeah certainly.
I mean, the first research I read was colon. You were a gastroenterologist, of course. So the first research I read was colon cancer.
Yes.
Well, when did you first learn about that, the link between vitamin D deficiency and colon cancer, do you think?
Which when I first learned about vitamin D, basically.
Right, so about late 80s.
1990, yeah.
Yeah.
Or the late 80s, yes,
so that's
indeed.
35 years ago, 34 years ago, 37 years ago, and still it hasn't been implemented.
Yeah, that's right.
How long does it take for science to transpose into these bodies, getting their act together and updating their guidelines? It really just beggars credulity how long that's
You
taken.
mentioned about the... You mentioned about the calcification in the arteries. Well, it took a long time. I'm not sure it's even appreciated now that the arterial atherosclerosis is an inflammatory condition. It was first noted by Virchow in the late 19th century.
Famous
and
German pathologist.
He described TAMs, tumour-associated macrophages.
He was a clever guy, wasn't he?
Brilliant. And everyone forgot about that.
Yeah.
And everybody thought it was all about cholesterol.
Yeah.
Well, it's not, Cholesterol is there. Cholesterol is part of the defensive mechanism for inflammation. It's in the muscle cells of the arteries that the disease occurs. We don't get arteriosclerosis in veins. There's no muscle layer. We do in arteries. Fundamental difference. And it's chronic inflammation within the arteries that's causing the damage. And we can switch that off with vitamin D in a good dose. And we've got to get that good dose. No good giving people a silly little dose of vitamin D. We've got to achieve the target level.
Could that partly explain why, I mean, we've known for a long, long time that smokers were more prone to heart attacks, atherosclerosis.
Yeah.
So again, products from the smoke could be part of this chronic inflammatory process, isn't it?
Yeah, indeed, absolutely. Yes.
Because when you smoke, you get things go into the lungs, nicotine and lots of other components from the cigarette goes into the lungs, circulates around the body.
Yeah.
Causes chronic inflammation.
Yeah, absolutely. And also, and with smoking, we get recurrent bronchitis, recurrent infections in the lungs. And it's these infections in the lungs. The lungs is the main way in which microorganisms get into the body.
Yeah.
The GI tract as well, but the lungs in particular.
So is there any advantage to taking, what I tend to take about 8,000 units most days when I remember. I probably remember about 5 days a week.
Yeah.
Is there any advantage to taking it daily, weekly, monthly?
Well, as we get back that slow process of processing of it in the liver before it goes into the blood properly. Say when we measure the blood level of vitamin D. We're not measuring vitamin D in its raw form. We measure it in its liver process form, 25-OH-D or calcifediol. We can take it easily once a week. I take it once a week. I take 40,000 units once a week. If I forget on the Sunday, when I usually take it on the Sunday, if I forget on the Sunday, I take it on the Monday or the Tuesday. If I miss it one week, I'll take double the dose the next week. I won't come to any harm by missing a weekly dose, quite honestly, at all.
Yeah, because it's chronically, constantly topped up.
Yeah, it's convenient to take it once a week. I'm very happy with that. Mm-hmm. Some people take it just once a month. 100,000 or 200,000 units once a month. Can probably get away with that. But I think once a week is probably a sensible way to do it.
Mm-hmm. Just occurred to me, would it be easier to overdose on if we don't do it in this country? I know they do it in Italy. When you get an active infection, you actually take the activated form, the Calcifediol. Would it be easier to overdose on that than it would be on the raw vitamin D, do you think?
Probably.
Yeah.
In fact, the activated calcifediol is measured in micrograms on the container.
And it's the equivalent. It's the kind of equivalent unit, isn't it? So
it is. Yeah.
You would take the equivalent dose. So if you got acute infection and you took 10,000 units or 20,000,
but it's only when it's only when you're very ill that you need to take that. When you need it straight away. Yeah. Yeah. But as a routine, it's not necessary. Yeah. It's best not to. It's best not to take it in its.
Just take the raw form.
Absolutely.
And then when you are ill, you're topped up.
Yeah, that's right.
For the thousands of patients that come into our care who aren't topped up, we give them antibiotics, but we don't give them the activated Calcifediol. Right. I think what I know now from your teaching and David Anderson's teaching, I think not to give that is now unethical.
Yeah. See, every intensive care unit should have a big stock of Calcifediol. But in this country, we're only allowed to give it to farm animals. It's not available for humans in this country.
It's not in the British national formulary.
It's not, absolutely.
It's unbelievable.
It is. It's available in Italy, available in Spain. It might be available in Australia, actually, now, and possibly in Germany.
Interesting.
But it's not available in this country. It's criminal.
So you, as a consultant physician in a hospital in this country, are completely unable to prescribe a life-saving Calcifediol preparation.
Yeah.
It's just...
It is. It's quite remarkable.
I mean, we're sniggering because of the ludicrousness of it, but people die because of this.
Yeah. My daughter has a friend who lives in Spain or visits Spain frequently, and she asked this friend to bring back some of the Calcifediol, which she did.
Yeah.
And and I had it, but my daughter kept some as well. And a friend of his was who was Indian ethnicity. He was taken into hospital, very, very ill, with COVID-19. And I said to Caroline, make sure he takes 2 of these when he goes into hospital, or as soon as possible, I said.
Yeah.
2 as soon as possible, and then 1 at weekly intervals while he's in hospital. Anyway, he did that. He took 2, and he took the packet into hospital with him, gave them to the nurse, said, I've got to take 1 of these every day, every week, while I'm in hospital. Now, I think this regime was 2 to start with, which he took.
Yeah.
1 after 3 days, 1 after 7 days, 1 after 14 days. That was the regime. Mm. So he got to hospital, he told the nurse this. She took the tablets off him, he never saw them again. But he'd taken the 2 capsules of Calcifediol, and he was fine.
Probably what saved his life.
Yeah, could well have saved his life, knowing how people of Asian ethnicity fared at the start of COVID.
And it's really quite moving. In the back of your book here, this is the book you co-wrote with David Anderson. In this one, we have pictures of the people that left us, mostly with dark skins in COVID.
These were not statistics. These were real people. There are the names and photographs there. There were 26 practicing doctors died in the first between March, April and the beginning of May 2020. And of the 26 who died, 25 were of South Asian or Black African ethnicity. And that has been neglected, forgotten about, ignored. And I'll tell you what happened then, that I'd identified that this was happening. David Anderson, being in Italy, had access to Calcifediol and vitamin D. It was just vitamin D at the time, actually. And our friend Parag, who's professor of endocrinology in Western-super-Mare, Parag Singhal, he was chairman of what's called BAPIO, the British Association of Physicians of Indian Origin. And he sent an email to all the members saying that it's essential that you take vitamin D, and if you're short of it, we can supply it. David Anderson will supply it. He sent it the same email to the secretaries of the other, like the British Association of Nigerian Doctors, etc., etc., etc. And that went all round. And the deaths of ethnic minority doctors stopped in the middle of May. There was one, the last one, who was a GP in Ramsbottom, I think it was, close to where we are now. And he died, I think, on the 3rd of May, might have been the 10th, 3rd or 10th of May. 2020. The next one I saw reports of dying was in September. So it was 25 ethnic minority doctors dying, March, April, and the beginning of May.
And then after your advice, that went down to nothing.
Yeah.
So you've saved the lives of possibly hundreds of doctors.
Yeah. Parag Singhal, who did it all, he saved so many lives. He did what the Department of Health should have been doing, what the British Medical Association should have been doing, what the Royal Colleges of Physicians, General Practitioners, etc. should have been doing.
But should have been rolled out to the whole population, not just the doctors.
Yeah.
I mean, saving the doctors' lives is wonderful.
Yeah.
But, we could have said, and of course the vaccines didn't come in till, we're not going to debate the vaccines,
later.
but yeah.
A year later,
into 2021,
Yeah, the horse had bolted by then, quite honestly. It was just terrible.
Absolutely.
But the word has got around, and I have a few neighbours who are doctors, mainly general practitioners, not all, no, of South Asian ethnicity. And they tell me that their patients, the general practitioners tell me, they're recommending vitamin D for the patients, and the vitamin D is being taken, but not in a very well supervised way, I must say.
A bit haphazard.
It is haphazard, but they are doing it.
But
they're not checking the blood levels because they're... Excuse me. They're not checking blood levels. They're discouraged from doing so. They're told not to check blood levels.
It took me about 2 years to get my GP to check my vitamin D levels.
It's amazing, isn't it?
And why on earth with such a basic test? They're quite happy to check your PSA, which is good.
Absolutely, yeah.
Or your blood pressure, which is good.
Or
your blood sugar levels, which is good. But why on earth not another... The other thing that I found really unhelpful at the start of the pandemic, 2020, was the increased death rate, and there was an increased death rate in people of ethnic minorities in the UK, for example, was because of social inequalities. Well, these consultants, these doctors, weren't in lower socioeconomic groups.
They weren't.
They were mostly consultants.
There was no socioeconomic deprivation among doctors of any ethnicity. But you can take a doctor, a young doctor from who origins would say Sudan, who was at risk of COVID-19 death in this country. His risk of death was about 1,000 times greater than that of his brother in Uganda. On the equator, loads of vitamin D, whereas living in London, going to be vitamin D deficient in a big way.
And you're dealing with people there from the same background, so they probably have the same
Yeah.
immunological exposure to different bugs when they were children and the same fetal
I
life.
doubt very much if the Ugandan doctor living in London was socially deprived compared to his brother living in Uganda, quite honestly.
Yeah, I think most doctors earn about $300 or $400 a month in Uganda, and slightly more.
Yeah, indeed.
Slightly more
Absolutely.
in the UK. Now, vaccination. We're not going to argue about vaccination and side effects, but giving COVID vaccinations, for example, generates an immunological response. Would that use up vitamin D in the same way that active infection would use up vitamin D?
I think so. The experimentation, to my knowledge, has not been done. But if vaccinations are stimulating an immune response, they're going to use up vitamin D in exactly the same way that an infection will stimulate an immunity response.
Resulting in
so giving people repeated injections of vaccinations, if they get these repeated infections, repeated immunisations, they're going to become depleted of vitamin D. And I think that's probably what's happening in our society at the moment.
In fact, Professor Anderson goes further. He says that no vaccine should be given unless someone's vitamin D status is first ascertained and checked to be adequate.
That's
because
sensible.
It's going to deplete the vitamin D, and you're not going to get an optimal immune response.
Yes, indeed. That seems a sensible approach. You know, the importance of vitamin D is overwhelming, but it's just neglected.
Yeah.
And I can't understand why that's the case.
So everyone needs to optimise the vitamin D levels, and sick people who are low on vitamin D, in our view, should be given the active form of Calcifediol to work within a couple hours. And the fact that that's not being done, I consider to be unethical.
Yeah, I agree.
Given what we know now.
Yeah.
Dr. Grimes, thank you so much for that. Absolutely fascinating, but yet still somehow just common sense.
Well, thank you for the opportunity to speak to you, John.
Common sense isn't that common.
Trying to get the information out, the importance of vitamin D.
Let's hope this is a small contribution to that.
Okay.
Thank you very much.
Thank you, John.